I think we finally managed to do it. Thank you,
Okay,
Stephanie.
let me go to Facebook too, okay?
Okay. So,
Okay, all right.
sorry
Hi.
everybody. We've had some technical difficulties trying to see if we can get this up and running. So, my extreme apologies that we're a little bit running late here. Um, I am hoping that everyone can see me. If there are any viewers out there, please put a little wave so I can see that you're out there. Um, I looks like I'm live, and it looks like I'm going to get started, I guess. So sorry about the delay. Um, well, hello, Facebook followers. Welcome to this week's installment of our series, Ask the Midwife. Thank you, thank you to all who have joined us during past sessions, and to those who will join us for our future sessions, and for sharing some of the information that you've learned over the course of these things here with us, and maybe you want to share. I know share some of this information with those who might benefit from it. So again, my name is Diane Jaworewski, and I am a registered midwife with the Midwifery Collective of Essex County. I am going to be your hostess this evening for the next 45 minutes. I apologize again, it was a little bit cut short. To chat more about midwifery services, and more specifically the midwifery scope of practice, and what that looks like from a more broad perspective. So basically from like an Ontario legislative kind of perspective. So basically that means in translated legalese, it kind of means what kind of care can be provided by midwives, when can that care be provided by midwives. And also we're going to kind of delve into what a midwifery scope of practice actually looks like in Windsor, Essex. Because throughout communities across Ontario, that care might actually look a little bit different depending on care providers, hospital policy, institutional policies, physician policies, and those sorts of things. A disclaimer statement for this evening. I must tell you that all of the information that is shared today is purely for educational purposes only. None of the information shared here today is actually meant to replace medical advice. Any clinical questions that might arise through our discussion today, I would encourage you to reach out to your most responsible provider that relate to your own personal health care. All right. Please know that tonight's Ask the Midwife session, along with all of Ask the Midwife sessions, are actually going to be available through our Facebook page, and also we have a YouTube channel. That's quite exciting. If you search Midwifery Collective of Essex County on YouTube and hit subscribe, you will have access to all of our informational videos of the past. So that's kind of an exciting little piece. Please feel free to share the links to our Facebook page, links to our Ask the Midwife sessions to your friends, to your family, to your family friends, to your friends of family's friends, or anyone who might be interested in midwifery care. Or who might be seeking information, if they're going through a pregnancy, getting ready for the birth of a child, whether or not that be a vaginal birth, a cesarean delivery, multiples. Someone who might be preparing for labor, preparing for parenthood, and someone who might want to discuss around expectations in the postpartum period. During the course of tonight's chat, please feel free to type your questions in the comment section. It's going to scroll up a little bit here so I can see. Perfect. And I will do my best to answer. I do get distracted quite a bit. You might notice cats in the background. I apologize. We got 2 little kittens during COVID. But if I don't get to your question right away, please use the attention-grabbing emojis out there. I do love those to remind me to look at the chat box every once in a while. This is my first time doing a Facebook Live video, so please bear with me. For those who are joining us maybe for the first time tonight, I would like to just take a minute to talk around, to speak about our practice around Midwifery Collective of Essex County. Our practice consists of 6 registered midwives, providing primary perinatal care to low-risk, healthy people and their newborns in Windsor and Essex County, and a small portion of Chatham-Kent. Our catchment area does go a little bit into Tilbury area. One of our midwives actually also provides supplemental care, not only to midwifery clients, but also to obstetrical patients, for those who may have more complicated pregnancies and require higher level care from an obstetrician. So that's a really nice piece there as well. We do have clinic locations both in Windsor and in Leamington in order to provide your family with personalized prenatal, labor, birth, and postpartum care 24 hours a day, 7 days a week, 365 days a year. And I just wanted to make mention it's really important for us to be able to provide care even out in the county. Part of the goal of healthcare is to provide the safest care, the closest care possible. So it is quite convenient to have care out in the county as well. So let's see. All the midwives in our practice are registered with the College of Midwives of Ontario. We'll talk a little bit more about what that means today. And are also members of the Association of Ontario Midwives. One of our midwives is also a board certified lactation consultant and can help support you or someone you might know in your or their journeys through newborn nutrition, even if you're not a midwifery client. This program is called Expecting and Connecting, so please check our website for more information about our exciting programs. Okay, so let's take a quick peek. I'm going to check in and see if anyone's out there. We got 6 viewers, it looks like. Oh, hi Tina, thanks for joining us. Really nice that you could join us tonight. I guess let's now talk a little bit about what the scope of practice of a midwife is. Midwives are what we call regulated healthcare professionals, so we are governed by law. We are actually a self-regulated profession. So what that means is that we do have a College of Midwives of Ontario. So just as a physician would have the College of Physicians and Surgeons, just as nurses have the College of Nurses of Ontario, just as dentists have a College of Dental Professional Association, I'm not quite sure, please, I probably just butchered that, College of Dentists of Ontario, any regulated healthcare professional will have a college. The role of the college is actually to ensure that midwifery, our college, is meant to ensure that midwifery services provided to the public are delivered in a safe and ethical manner by midwives. So part of this involves ensuring that midwives understand their scope of practice and practice within those borders. Okay. So this is our governing body, just like I mentioned. The college of any given healthcare profession exists to provide a high standard of care throughout the profession. So it doesn't matter if you're seeking care in Cornwall or Thunder Bay or London or Windsor or anywhere above, below, east, west, in between. The care that you receive from a midwife in this province is standardized via our college. Okay. The college, has the professionals every year recertify in certain things. It is part of our mandate that we do recertify in certain emergency skills, neonatal resuscitation, CPR, first aid, and that we do provide, information about the continuing education that we're doing. Any regulated healthcare professional, including midwives, absolutely are required, and also we desire it to always further our education, keep up to date with the most up to date research around the best possible care to provide. The College of Midwives is the governing body that actually holds our licensure. So, and the college also upholds the legal acts of each profession, which dictates what a provider can and can't do. So, for example, a midwife cannot perform a knee replacement, kind of just like an ophthalmologist can't do chiropractic maneuvers. So it's the same kind of deal. The scope of practice of a midwife is defined by the college as the practice of midwifery is the assessment and monitoring of people during their pregnancy, labor, and the postpartum period, and of their newborn babies, the provision of care during normal pregnancy, we'll talk about what that means a little bit, labor and postpartum period, and the conducting of spontaneous normal vaginal deliveries. So that's a mouthful. What does that mean exactly? The legislative scope of midwifery practice consists of the scope of practice statement from the College of Midwives, The controlled acts authorized to midwives, and that's found in the actual Midwifery Act, which was passed back in 1991. There is another piece of legal allowance for us to perform our jobs, which is it's a list of the laboratory tests that midwives are able to order. And we also do have, a list of drugs that we are able to prescribe. It's a small list of drugs, definitely. Every once in a while, that list is reviewed and sometimes revised, and we add or take away drugs, that are beneficial or maybe have gone out by the wayside. But that is updated. I know right now I think they're looking into updating that list again. So. Let's see here. So in essence, the midwifery scope of practice are the activities, decisions, and tasks that a midwife is permitted to do by law. The midwifery scope is a legal boundary, so it is not flexible and cannot be expanded by practitioners, regulators, or institutions. Scope changes can only be achieved through legislative change. So that's a bunch of legal jargon, definitely, but it is a lengthy and onerous process for when these acts are opened up. So, yeah. So I'll just take a minute for quite a moment and see if there's anyone that has any questions so far about what they've heard. Hi, Jess. Thanks for joining. And hello, Jessica. Nice to see you. Thanks for saying hello. Let's see. Any other comments or questions here? Okay. So I don't see any comments or questions at this point yet. So I guess what I'll do is I'll kind of continue on about what that might actually mean for clients, about what the legal scope of practice is for midwives. So midwives are trained to provide care to generally healthy, low-risk people during the pregnancy, labor, and postpartum. Let's talk about normal for a second, because I think that has a lot of different meanings for a lot of different people. So I think it's important to kind of stop and maybe take a minute to kind of define what normal might mean. Our college actually defines normal as a clinical picture that is considered healthy or uncomplicated. So that doesn't necessarily mean that there can be no underlying health conditions, nothing in your health history past or surgeries in your health history past that might preclude you from accessing midwifery care. That normal just means that it applies to kind of like the overall health status of the individual and does not necessarily rule out the presence of a specific condition or indicate the complete absence of abnormal. So like I said, normal can mean a lot of different things. So normal can include infections. Normal can include conditions. Thyroid conditions are a really good example. We do see quite a few of those. Any clinical presentations that require monitoring or treatment where the overall health status of the person is healthy, then that would be considered as normal as per our college. Determining if a clinical situation is normal requires clinical judgment, which our scope of practice allows us to exercise that type of judgment. So as I mentioned before, the college actually makes sure that midwives understand what would be considered in that scope of normal. Sometimes determining whether something is normal or not might require diagnostic tests or lab tests or ultrasounds or consultations with other providers as well. So some things that are not necessarily pregnancy related or pregnancy specific might require investigations done by either your nurse practitioner or your family physician or an obstetrician gynecologist, or sometimes a neurologist or sometimes a rheumatologist. It just depends on what the clinical situation is. So I'll give you a kind of a little example. I mentioned thyroid concerns. I would say there's quite a decent population that has hypothyroidism. And people who have hypothyroidism are generally managed by having a thyroid supplement or thyroid medication. So usually what happens is either a family physician or an endocrinologist will manage that part of the person's health, and then the midwife would be able to kind of carry on and manage the pregnancy, labor, and postpartum in conjunction with the other healthcare provider to make sure that that person gets exactly what they need to make sure their health is top notch. Okay. So I'm just going to take another quick peek. Jess, that is kind of a complicated question. So Jess asks, could you give examples of abnormal, or is that too complicated? So abnormal can mean a lot of different things. I'll give you probably the most common ones that we find in our practice. Blood pressure concerns. That can be a big one. So if someone, develops significant blood pressure concerns, they're symptomatic for high blood pressure, their blood pressures are regularly higher than what they should be, they're spilling protein into their urine, that client population definitely needs a little bit of higher monitoring in terms of making sure that the pregnancy remains okay to continue, because high blood pressure could in fact lead to conditions like preeclampsia, endoclampsia, seizure-like activity, intrauterine growth restriction, those types of things. So high blood pressure would be one of them, would be something that's considered higher risk. Another one that we see sometimes is gestational diabetes. That is insulin dependent. So two different types of gestational diabetes can occur. There's diet controlled, which the sugars are more easily controlled by diet and exercise and modifications that way. But sometimes that's not possible, and sometimes a person might need to actually be on insulin. So if a person requires insulin, that definitely requires higher level care. So that is something that would be considered maybe abnormal. Okay. What would be another one? Oh, placenta previa. Placenta previa would be a good example of abnormal in a pregnancy. Someone who has had or has epileptic seizures in the past, that would be something that would be considered requiring further investigation or requiring further monitoring. I don't know if that helps. Does that help, Jess? All right. So let's see. So midwives, as I mentioned, are kind of low risk specialists, and as such, we do manage accordingly. I would say the vast majority of people entering midwifery care, or the vast majority of birthing people, do have relatively uncomplicated pregnancies, I would say. But we are trained, obviously, to recognize and identify when things might not be going down that normal path, which is this whole scope of practice conversation. So let's say, for example, Jess, we kind of talked a little bit about some of those conditions. Let's say one of those things kind of present themselves, and a person might need, higher level care. So that can look like one of two things. It can either look like a consultation with the most appropriate provider. So let's use high blood pressure as an example. In a pregnancy, if high blood pressure kind of comes up, we might consult with an obstetrician, do a bunch of, lab investigations, do some fetal monitoring, and the physician might actually, after the information is provided, might decide, okay, this person could benefit from an antihypertensive medication. So that would require consultation. Doesn't necessarily mean a transfer of care to a physician. It just might mean that we need to check in periodically with the obstetrician to make sure that your blood pressure is remaining, somewhat stable, and that your symptoms aren't worsening, and that the baby is okay as well. Sometimes if there's a complicating factor that is not managed by conventional methods, then absolutely your care would be best then managed by a physician. So that in fact would be a transfer of care to a physician. Now, a transfer of care, we'll talk a little bit more about that, about what that means in this community. But a transfer of care in general does not mean that you lose out on your midwifery care. It just means that your care needs to be managed by higher level care providers like physicians. So it just means that if you needed, ultrasounds to be organized, serial ultrasounds to kind of check in on the health of your baby, if you need increased numbers of visits, or increased investigations that a midwife might not be able to order, then it would mean that your physician would be responsible for managing all of those things and communicating, those recommendations to you. But again, your midwife doesn't have to be out of your care altogether. This is a client's choice. I would say most clients choose to have their midwives remain involved in their care in a supportive care capacity. So sometimes what that means is a person might want to come to their regularly scheduled prenatal visits on the same schedule that they were with us. Sometimes they're also doing that with an obstetrician. So if it gets to be kind of too much and too hectic of a schedule with ultrasounds and blood work and visits with their obstetrician or another kind of physician, then sometimes we might offer, phone visits, phone check-ins. If a person's on bed rest, we do home visits if you're at rest at home, or if you are hospitalized for any reason for monitoring, we can do hospital visits as well and check in with how you're doing, how you're feeling. Not only are we there for clinical monitoring and managing, those sorts of things, but we're also checking in on how you're doing. How are you doing emotionally? How are you finding yourself, preparing for what's coming next, and just talking some of those things through with your midwife. So that's kind of the role a midwife would step into if there was in fact a transfer of care. Let's see here. All right. Okay. So, sorry, I forgot to mention as well that midwives, again, that we are all credentialed at both hospitals. So we are all credentialed at Windsor Regional and at Erie Shores Hospital. So why I mention that is because if you do in fact require supportive care and you'd like supportive care, that we are credentialed professional staff at both hospitals. So we are able to come in and see you at the hospital. If your baby is in the neonatal intensive care unit, for example, we are able to come, and provide those visits while you're there and while your baby is there as well, to kind of go over, feeding and to go over skin to skin care and all of those things, and just kind of check in with how you're doing. Any questions at this point? Anyone have any experiences where you've had midwifery care either in this community or in other communities, where this has been the case, where your care may have become a little bit more complex, or you've had kind of supportive care from a midwife? Has anyone experienced that? All right. So I'm going to take that silence as a no. I guess what we'll go over now is kind of what the scope of practice in Windsor, Essex looks like. So as I mentioned, the scope of practice is kind of a legal parameter for what midwives can and can't do, and that also is sometimes up and open for discussion and changes to that legislation. So I guess the most recent examples of that would be that I want to say a number of years back, for neonatal resuscitation, the intubation and umbilical venous catheterization and medications for newborns was actually added to the midwife scope of practice a number of years ago. So that's a good example. Things like, oxytocin, actually, that was another big one that's been recently changed, is that oxytocin is no longer specified for us to use only in the prevention and the treatment of postpartum hemorrhage, but now oxytocin has actually come into midwife scope of practice in order to use for induction purposes or for augmentation purposes of a labor. So those are some kind of really exciting changes and there's changes that are happening all the time. As midwives, our role in the healthcare system is actually quite important in terms of providing really good outcomes for moms and babies, or birthing people and their children. but also to kind of protect the healthcare system a little bit. When providers are enabled to work to their full scope of practice, we know that it saves the healthcare system dollars and it actually improves outcomes for everyone. So that's something that's pretty exciting. And why I wanted to mention, the scope of practice within this community, it is a little bit different than what I've been hearing. We have some clients who have come from different communities, and even our colleagues in different areas throughout the province, we kind of, chat with on occasion and kind of, listen and hear, what their practice is kind of like. So, in this community, we do practice to full scope. So what that means is if a client chooses an epidural, their labor care does remain in the care of midwives. Whereas in some communities, if a client does choose epidurals, that care is then transferred to an obstetrician, which is interesting. There are some communities where if a person requires induction or augmentation of labor using oxytocin, then sometimes that is also a transfer of care to a physician. Some clients who choose a trial of labor after a cesarean section, that could be a transfer of care. Some people who, what's another example? I guess those are the main ones I would say. So in this community, I would say that we do have a very low transfer of care rate. So we do manage epidurals with the help of the nursing staff, of course. We do use oxytocin for the purpose both of induction or augmentation of labor. So we don't have to transfer care for that. What else I would say? I would say those are the main ones for labor. And during pregnancy, I would say also that the midwives of this practice, we also have really good working relationships, both inside and outside of the hospital with the healthcare team, with the obstetrical care team. So we do have good communication, good working relationships with the obstetricians. So sometimes if care sometimes does go, a little bit veers off the path of normal, then we sort of work together as a team. So the midwife will work to his or her scope of practice. In this community, we only have female midwives. Will work to their scope of practice with, of course, with the advice and the expertise of the physician who's on call as well. So we definitely take a team-based approach when it comes to any kind of complications that happen. And of course, that team includes the client, is at the heart of the team, actually. So between everyone who may become involved, that the client themselves are really at the heart of all those discussions and gets to make those decisions. Let's see here. I think I saw a question pop up here. Oh, hi, Lily. It says here, is there any form of pain relief that midwife can administer? So that's an excellent question, and I would say, depending on where you're looking, if you're talking about home or hospital? So when we're talking about a home birth, the type of pain relief that a midwife can administer are recommendations around, let's do some position changes. Let's show your laboring partner how to support you physically, how to put some pressure maybe on your back, or how to do some hip squeezes, how to support you in the shower. Maybe that means recommending getting into the tub. Those sorts of things. So at home, no, there's no medical kind of pain relief options that can be administered at home. In the hospital, the epidurals are managed and are placed by anesthesiologists. Sometimes, in early labor, let's say, for example, if a person is having a lot of, prodromal labor, or kind of, I don't like to call it false labor because it's not really false labor. It's just your body warming up for the actual main event. But sometimes that process can go on for a little while. So if that's the case, we can consult, with the obstetrician and get some pharmacologic pain relief in terms of, narcotic. Sometimes IM morphine can be given. Sometimes just Tylenol and Gravol and those sorts of things. Nitrous oxide is another one that midwives are allowed to administer, although currently due to COVID, that's not possible quite yet. But yeah, so those are some of the things that midwives can administer. I don't know if that helps. Oh, oh, hello, Caitlin. All right. Well, I look forward to it. Let's see. What else can we talk about scope of practice in this community? Yeah, I would say that's pretty much it. I would say that during pregnancy, sometimes things arise in the postpartum as well, that you might require some extra help. So some of the most common things would be they're not really common, but some of the things that we have seen have been, if you need an ultrasound postpartum to make sure that if you're having heavy bleeding, we want to do an ultrasound postpartum, or you need a medication to kind of help the uterus evacuate a little bit more quickly, any kind of placental tissue or any clots that have kind of developed and those sorts of things. So that might require another, a consultation. But I would say the vast majority of our consultations don't necessarily turn into transfers of care. And I would say probably, I don't ever recall a case of us not being requested to remain involved in somebody's care when their care has been transferred to obstetrician. So yeah, I would say that the scope of practice in Windsor, Essex is quite full, which benefits the clients. I think it really provides that continuity of care that people, I feel, the people that I've spoken with, I do feel people crave that continuity. So they have a familiar face with them. They have that trusting relationship that they've kind of built over the last, I would say 6 months of the pregnancy, because often we start seeing people around the 11, 12 week mark. So yeah, I would say that our scope of practice is quite full here. We look forward to eventually, even if that scope of practice does enlarge and does kind of include other things. So for example, pap smears are something that midwives have been doing for a very long time. Down the road, there are midwives actually in other regions, like in Hamilton, who are placing intrauterine devices for birth control and those sorts of things. So there's lots of growth potential for a midwife scope of practice, and we're really excited about kind of exploring some of those potentials. Let's see here. Oh, I missed a question here from Jess. So a typical appointment, do you mean like a midwife appointment, Jess? Is that what you're hoping to? Okay. So, a prenatal appointment, your first prenatal appointment can be, about an hour long, I would say. So we kind of go over, what a midwife does. We kind of go over all these things that we're kind of going and Ask the Midwife videos. We talk to you, we do a health history, a targeted health history. Every visit that you come subsequently is about a half an hour in length, so that you have time to talk about what you need to talk about. We have time to talk with you about upcoming tests or upcoming events in your pregnancy or preparing for labor, and those sorts of things. Do blood pressure, a weight check if you choose. We listen into the baby for fetal heart rate. And then we make a plan to see you again. So we see you on the same schedule as what a physician would. A postpartum visit can look like a number of different things as well. So a postpartum visit can be done in hospital. A postpartum visit can be done at home. And postpartum visits are also done in the clinic. So for those visits, definitely, again, still at least a half an hour in length. Sometimes your last visit with us is about an hour, so that if you needed a pap smear or if you needed some more time to kind of, talk about your birth and talk about your experience and those sorts of things, we definitely provide that sort of time for you. I hope that answers your question. I think I have another question here from Kelly. Okay, so Kelly asks, how common are VBACs in our community? I can speak definitely from our practice perspective. I don't have those numbers, from a community-based perspective. But if you would like, you can maybe leave a message, and it might be something I can actually pull up some stats for you. But I can tell you in our practice, we do have quite a few people who are, our C-section rate in Windsor, Essex is just about average for the provincial average, which stands around the 30% mark. Don't quote me, it's not 30%, but it's around 30%. So depending on what a person chooses, a VBAC, I would say, I know that the number is about 75% of those who attempt a VBAC or a trial of labor after cesarean are successful. So it definitely depends on perhaps the reason for the first C-section in the first place, and whether or not that reason persists or happens again in a subsequent pregnancy. It also depends on the status of that pregnancy in the moment. If there's other complicating factors for a VBAC. So for example, if there is a low lying or a placenta previa, that would be another indication to have another C-section. Or if there was extensive trauma to the uterus during the first labor and birth, that might again be another indication to have another C-section. But I would say the 75% of people who opt for a trial of labor after a C-section are successful. All right. Perfect. So, are there any other questions about the scope of practice of midwives in this community? I'm just going to pull up my last little blurb here that I've got for you guys. Oh boy, so many emails. So I invite, like I mentioned before, people who have seen this today, people who have seen past videos, to please feel free to share this information. I think the more open access to midwifery care for people, obviously it's good for everyone. I think that we're excited to meet new clients. We're happy to care for past clients, and we're always excited to bring midwifery care to those who may not know about it, actually. So, and I feel like that can be an issue. It can be definitely an issue. So, midwives are self-refer. So if a person finds themselves pregnant and really interested in midwifery care, you don't necessarily need a referral from a physician, from your family doctor or nurse practitioner. You can actually contact our clinic. So in order to apply for care, we do have an application process. So we do have our website, midwiferycollective.ca. There is an application form on there to fill out. So once you fill out that application and submit it, our administrative staff kind of reviews it. We look and see, how many due dates we have for the month that you believe that you are due in, and then we kind of make a plan going forward from there as to, yes, we have a space for you, or we might have to put you on the waiting list if we don't necessarily if we have a full month that month. So that's how you would apply for care. Let's see here. I'm just trying to find our little thing here. All right. All right. Be sure to join us, next week for our next installment of Ask the Midwife. We're going to be running these, I think, for the next foreseeable future on a weekly basis. I do believe next Wednesday, June 28th, or sorry, June I missed a month. July 28th is going to be with Andrea, our midwife, Andrea, who runs the Expecting and Connecting program. And I do believe her topic of conversation is going to be what to expect in the first week after you have your baby. So whether or not that's a home birth or a hospital birth, just some expectations around what it might be like when you bring your newborn home, or if you've had a home birth, what that might look like over the first week or so. So we're really excited to have that happen. Let's see here. I think there's like any more questions here. So nice. All right. Wonderful. So is there anything else I can answer for you before we sign off for the evening? All right. Oh, Jess has a question here. So Jess's question is, what happens if a lady tears at a home birth? Ooh, that's an excellent question, Jess. So it is quite common, particularly for people who are going through the birthing process for the very first time, to have a little bit of tearing at the time of the birth. Part of our management of the third stage of labor while someone is pushing is to definitely support those perineal tissues, to really have someone kind of listen to their bodies to when they need to push, to support the perineum, using warm compresses, or having the person themselves, put their hand to where the baby's head is going to be emerging from, so they can feel exactly how much pressure and where to put that pressure. So our whole goal is to help to prevent perineal trauma or perineal damage. But obviously, we recognize that that's not always possible. There's many different factors that might go into, if somebody is going to tear or not tear. So if a person does in fact require stitches, it is within the midwife's scope of practice to repair first and second degree lacerations. So that means, the superficial skin of the perineum, as well as kind of the first layer of muscles that hold the perineum up together. It does not involve, midwives cannot do repairs for people who have had tears third and fourth degree. So what that means is that the tear would involve, rectal structures. So whether that's the fascia around the rectum, or whether or not that's right through the muscle itself. But first and second degree tears are within the midwife's scope of practice to repair. We do carry with us for home birth suture material, and actually lidocaine as well. And we carry the lidocaine. That's obviously a local anesthetic. It can be quite tender, especially after you've just had a baby. So we do carry with us those things, and the midwife can repair first and second degree lacerations at home. If it is beyond the first or second degree, then that usually indicates, it's an indication for a transport into the hospital, so that the obstetrician, you want a surgeon repairing a third and fourth degree tear, as it is outside of our scope to do that. So that would be a transport into hospital and a consultation with a physician to make sure that that those tissues would heal well, and continue to be strong for you, throughout the remainder of your life. Great. All right. Well, it looks like we've got about 4 more minutes. So I've mentioned, our next Ask the Midwife, which is wonderful. Please feel free, if you haven't seen all of our Ask the Midwife videos, feel free to go back and review them. We really do look forward, to hearing from you all, and to seeing you all that are in here currently. And you know, we ask that you pass along this information to anyone who might need it, or maybe not need it, who might benefit from it, who might be interested in midwifery care, or you know what the scope of midwives actually is. And again, don't forget about our Expecting and Connecting program as well. So even for those people who fall outside of the scope of midwifery care, have access to some elements of that care as well, which can be greatly beneficial. So yeah, we thank you so much for joining us for this evening. Again, I'm so sorry that there was technical difficulties at the beginning. If there's any midwife that's going to have problems with technology, it's this one right here. So I apologize greatly. Is there anything else I can help you all with? I think that's it. So I think that's our conversation for the night. So again, I thank you all, and we'll see you real soon. Maybe someone even tomorrow. Thanks all.